Hi, I'm Dr. Martin Rutherford.
I'm Dr. Randall Gates.
So today we're going to talk about Hashimoto's thyroid disease. And this is the third in a series of presentations that we're doing on chronic pain. And we're trying to cut through the BS for you. And what we consider the BS is the misinformation that's out there relative to this condition. And this condition is kind of near and dear to our heart, because in our understanding and our constant search for what are the true causes of chronic pain, Hashimoto's is on the top of the list. Hashimoto's is a very confusing, very complex condition. And as little as 5, 6, 7, 8 years ago, Hashimoto's wasn't even really considered a real entity, a real treatable entity, or at least a diagnosable entity in the medical community, who largely treats thyroid hormones. It turns out that Hashimoto's is significant, and it's being recognized in the medical community as being so. More and more doctors are now running the antibodies, which we'll talk about, that will confirm whether you have them or not. But now we have a lot of other things coming out, because now that doctors are finding that Hashimoto's is prevalent, they're using a standard thyroid protocol of using medication for it. And frankly, in the alternative field, maybe a standard thyroid protocol of selenium or zinc or tyrosine or things of this nature, and it's not working. In large part, it's not working. So now people are starting to kind of create other methods or other suggestions of, well, let's just leave your thyroid kill itself and then we'll do something with it there. Or let's just get off of gluten and that'll take care of it. And there are probably isolated cases in which those are good suggestions, but for the large part, we're going to suggest, or we're going to discuss our reasoning, usually based on pretty sound literature, why those are not proper ways to go. And we're going to talk about the causes of Hashimoto's thyroiditis. And it's interesting because there's 3 causes that we know of, and we're going to talk about those, and we're pretty definitive on them, because when we find them in patients, and we help to correct them, these causes are the causes. I mean, the Hashimoto's attack against the thyroid starts to dampen down. Interestingly, one of those causes, and a very, very, very prominent cause of it, is brain function. And brain function is something that nobody who comes in here thinks could have caused their Hashimoto's thyroiditis.
Mm-hmm. And when you're saying it's was not a diagnosable entity back in 2005 to 2008,
people weren't diagnosing
exactly
it.
What Dr. Rutherford is referring to is that the singular focus from a diagnostic standpoint was, do you have hypothyroidism?
Right.
Do you not? Now, Hashimoto's has always been around.
It's like 1904,
I believe. Dr. Hashimoto Hakuro out of Japan first identified it. But now with the focus of Dr. Karazian and really his beginning research, and now how a lot of us have kind of taken the ball and run with it, we've seen that Hashimoto's is almost a separate entity from hypothyroidism as most of you think of it. So most of you just think, is my thyroid low or high? What are my thyroid hormone tests? But then so many of you are starting to realize, I'm taking thyroid hormone and I don't feel any better, which is where Hashimoto's as a singular entity is really, in our opinion, more important. And we'll talk about today how Hashimoto's relates to so many other conditions in the body and is almost like the canary in the coal mine for other autoimmune diseases as well as other endocrine problems. But you have Hashimoto's. So
Yeah.
why don't you kind of take the listeners and the viewers through Hashimoto's and your experience with developing autoimmune thyroid disease?
So I developed Hashimoto's. I developed celiac. Mm-hmm. I'm saying this for a reason. I developed probably an immune attack against my cerebellum. And many other things that I have not even bothered to look for at this point in time. But to Dr. Gates's point that Hashimoto's is a very important entity to chronic pain, it's because it really confuses the issue if you don't understand what we're about to tell you on this video. So I was undergoing a lot of stress back in the early 2000s. And I was involved in something that just was kept ongoing in my life. It was a big distraction. And then one day, I developed pneumonia. Now you're going to find out there are triggers for Hashimoto's. There are some very distinct triggers, and I think we're going to cover those. And the trigger for me was an overwhelming infection, One of the things we'll talk about is I have a history in my family. Now, understand it's unusual for a man to get Hashimoto's relative to a female. Okay, but I have a history in my family of thyroid problems. My mother had a goiter, my aunt had a goiter, both of them had their thyroid out. My grandmother had a goiter, she lived with it. I have an uncle who had MS, I have another uncle who had Parkinson's. So as you'll find out, when you develop Hashimoto's, you're usually already compromised host. I had that compromise. I had the genetic propensity to develop an autoimmune problem. And Hashimoto's is first and foremost an autoimmune problem. So I got sick, and the next thing you know, I was in bed for like 3 weeks, missed 3 weeks of work. So most people will tell you I hardly ever missed work in all the years I ever have been in practice. I couldn't get up. I put on a significant amount of weight. My hair started thinning out. My eyebrows started thinning. My bowels, which were never all that great in my life, went off the deep end. And I could go on and on and on with a lot of things that maybe you might not want to hear. And so, but my journey was, I'm in Reno, Nevada. I don't know how many of you know Reno, Nevada used to be the healthcare mecca of the United States.
Or the alternative mecca.
The alternative healthcare mecca of the United States, exactly, in the 70s and 80s. And I knew a lot of the doctors in town who were doing this. I went to many of them. And it's not to be disrespectful at all, but many things were tried. But it became obvious nobody really knew what was wrong with me. And the really first help that I got was to go to a functional neurologist and talk to a functional neurologist who was talking to me about the stress responses I had that had set me up for the overwhelming infection to set off the genetic propensity for me to develop fibromyalgia. I developed fibromyalgia, chronic fatigue, celiac, immune attack against my thyroid, peripheral neuropathy, and we'll talk about how the fact that I had probably had a permanent leaky gut from surgeries when I was a kid, from ulcers when I was a kid, how getting mononucleosis from Epstein-Barr virus when I was 21, all of these things came to play together that very time when I got the pneumonia, and I couldn't get better. And I used to be very athletic, and in a sense that I used to run and I'd jog and I'd ski. And after that episode, the chronic fatigue aspect, I literally couldn't do a treadmill for 10 minutes for almost 2 years. It was pretty amazing. So my journey was frustrating. I was told, maybe you're depressed. I was told by one of my medical colleagues. I was told you have heavy metals. I was told that, you probably have candida. I was told, all the things you probably heard. I've heard from the local vitamin store that it's parasites and you need to go under the machine, the Rife machine, and so on and so on. So I kind of went the gamut until I went to the gentleman who found that I had the chronic stress responses. And then I started doing his protocols and I felt better. But then I was directed by him to another doctor who was doing research on this back in the early 2000s, and his name was Dr. Karazian. Dr. Gates just mentioned him. He put out a book, Why Do You Still Have Thyroid Symptoms When Your Lab Tests Are Normal? I still think it's probably the best book out there on it. And I started to work through those protocols, through taking his classes and applying them. And Dr. Gates came in and his certification in neurology, he started to help me. And I'm 60, I'm about to turn 65, and I'm in pretty good shape as opposed to that. But it was a long journey back because I had to sift through all of the data out there that was unreliable. I'll just say it's unreliable. Maybe it's a little harsh to call it BS. Some of the stuff we're going to talk today is BS, okay? And some of the data is just unreliable. So we're going to try to cut that years and years of me getting from there to here for you down, and we're going to try to get all of that data and give you some certainty on what data online is actually real and what data online is actually not very reliable. And based on our experience of working with a couple thousand fibromyalgia patients and getting consistently successful results and properly selected patients.
Fibromyalgia, Hashimoto's patients.
Did I say fibromyalgia again? Hashimoto's and fibromyalgia are almost one and the same to me, and you'll find out why. Virtually every fibromyalgia patient who's ever come in here has tested positive for Hashimoto's thyroiditis.
Right, there's
virtually.
A big percentage, yeah.
I didn't say all.
All right.
He keeps me honest here.
Yeah, and so we're going to talk about that. We're going to talk about your journey becoming a functional medicine practitioner, transitioning into functional medicine, I'm a board-certified chiropractic neurologist, so we merged functional medicine with functional neurology to address these chronic pain complaints. Because, for example, we're finding that a lot of Hashimoto's patients, the antibodies to your thyroid are not just attacking your thyroid, they're attacking parts of your brain. And we'll relate it to inner ear conditions. If you have menstrual issues, reproductive issues, fertility issues, we'll talk about polycystic ovarian syndrome. We'll talk about the infamous gluten in Hashimoto's. But before we do all that, why don't we go to your office and kind of go through a consultation from the things that you hear commonly from Hashimoto's patients and what they're experiencing out there in the medical landscape.
Now, if you have Hashimoto's, I don't mean to sound self-serving or anything like that, but I think you're going to find this presentation very interesting.
So as we talked about in the introduction, there is a lot of confusion about Hashimoto's, hypothyroidism, thyroid disorders. So Dr. Rutherford, when people come into your office, why don't you kind of go through a standard history that you see with a lot of Hashimoto's patients and hypothyroid patients that they present with in their paperwork, as well as the other historical features that are common to this condition?
Okay, and I think this is a very good thing to do next, because this is usually a pretty illuminating part of our protocol. We try to evaluate our patients to make sure that if they're coming into our clinic and they're going to be willing to do the types of things that we do, where we try to evaluate them so that they're going to be able to get a consistently successful response. And this history is a big part of trying to determine whether that patient should even be evaluated here or not, on a number of reasons, for a number of reasons. But classically, Hashimoto's patients are pretty confused when they come in, for the most part. Some of them have even read my mentor's book, Why Do I Still Have Thyroid Symptoms When My Lab Tests Are, and are even more confused. It can be a pretty sophisticated book. But in the end, the reason that there's confusion here in the patient is because there's confusion out there in the healthcare field that is trying to take care of Hashimoto's and may not yet understand the full implications of it, implications which you are going to be very conversant with by the time we're done. So history is very important to us. As you know, if you are looking at this or you're viewing us because you have Hashimoto's, or somebody's told you maybe you have it, one of the first things you'll probably know in this time in space is that it's difficult to diagnose simply by going by the numbers. So the history is very important. It's interesting, I didn't realize this until I started doing it, but that the Hashimoto's patients come in with a very, very distinct history. This is what's allowed us to craft some responses to it that have been consistently successful. So Hashimoto's, first and foremost, is an autoimmune problem. And I kind of take it from that perspective when I'm doing the history. When a patient comes in here, there's still a small percentage of patients coming here who have never heard of it, don't know they have it. They've come in here with fibromyalgia or peripheral neuropathy or chronic fatigue, mainly fibromyalgia and chronic fatigue. And I'll have to start to try to help them to understand that they may have a thyroid problem, or they may have this thing called Hashimoto's. And as the patient walks through all of their diagnosis from the doctors, when it becomes obvious that the thyroid diagnosis is absent, or that they're not even aware that it could be, or they say, oh yeah, I've had my thyroid test and it was normal. Usually the first questions I'm going to ask is, so let me ask you, do you get like heart palpitations for no reason at all? Oh, yeah, not much, but yeah, well, yeah, that's intermittent. Okay, do you get intermittent heart palpitation for no reason? Do you get anxiety for no particular reason at all? No reason, just like, yeah, I get that. Insomnia, can't go to sleep, wake up, can't go back to sleep, night sweats, maybe some inward tremors for no reason at all. If the patient starts shaking their head, and the patient is sitting in front of me, and for the most part they're overweight and their hair is thinning, I can pretty much, I'm going to know they probably have Hashimoto's thyroiditis. And as Dr. Gates will probably talk about later, there's a small percentage of patients who show up thin. Mm-hmm. Okay, but we'll get into the specifics of that. So when the patient comes in, I usually shake their hand. I try to feel whether that patient's hand, if they have sweaty palms. I look at their eyes. I look to see if they have little flutters in their eyes. I start to do the evaluation and the history as far as the patient comes in. We'll talk a little bit about the significance of those in a few minutes as I get into the history. So I get into the history, and usually first thing I ask is, all right, so you've been diagnosed with Hashimoto's, you have Hashimoto's, you're not responding to the medication, they gave you the medication and you blew up, then they took the medication away from you and then you felt worse, or you got off the medication, you didn't feel any different than being on the medication, or you have every symptom, but you're taking the medication and your numbers are normal and the doctor won't give it to you. These are all signs to me, walking in the door, this chance of this patient having Hashimoto's is substantial at that point in time. So usually on our intake sheets, it says, when did your condition first appear? And interestingly enough, people put down 2006, or they might put down May of 2006, or they might put down May 15th of 2006. And the reason is frequently Hashimoto's can come on gradually, but frequently there is an exacerbating trigger that causes it. And the triggers are going to be overwhelming infections, they're going to be surgeries, they're going to be traumas, they're going to be, I just had my last baby and I haven't been the same since. These are several of the triggers. Stress, a stress response, an overwhelming stress response. These are some of the things that trigger immune responses. And as you're going to find out later, Hashimoto's is one of the most commonly affected autoimmune problems when physiology goes wrong and flares up stress hormones or flares up your immune system. So if they can give me a date, then we talk about the trigger. When I look at the rest of the history, and I've usually glanced at it before the patient comes in the door. We have a little video that tells people what they're going to experience when they come in here. During that video, I'm usually looking at their history. If I see they have food allergies, that's a big deal. You're going to find out what the food scent. And if they come in here and say, I eat a certain food and my throat gets hoarse and I get a little tender in here, most people think it's their lymph nodes, and then they point here, that's a sign to me that we probably have an immune attack against the thyroid. I look at their drugs, and the reason I look at their drugs is I want to see what they're taking for what. Are they taking some for acid indigestion? Meaning to me, as Dr. Gates may explain later, it may be that they have a thyroid problem, they may have a chronic stress problem. These are things, by the way, that cause acid indigestion. There are other things, but these are probably the two most common. Do they have high blood pressure? That tells me that they got a chronic stress response going on. Maybe they have some other things going on. We're looking at what pain medications are taking. Are they taking antidepressants? Are they taking something for their guts? Are they taking probiotics? Because these are a lot of the things that people will be taking to dampen certain aspects of physiology that dampen immune response against their thyroid. So we start to understand that even though these people, the patient who is sitting there doesn't realize that all of this is affecting their thyroid, this is building my case. And to that point, my biggest challenge used to be to convince people that they had a thyroid problem. Then my next biggest challenge as time went on was to convince people that there was no silver bullet. That a lot of people came here looking for the new herb or the new diet or the new botanical. Hashimoto's is about everything else that's going wrong in your body first and your thyroid next. And again, you'll understand that a lot better by the time we're done. And that becomes real obvious in the history. If I look at what surgeries the persons have, if they have a hysterectomy, if they have their gallbladder out, if they have their tonsils and their appendix out, I can pretty much assume that there's an autoimmune problem here. In the functional world, if you have one autoimmune problem, you're usually going to have others. And the second one that usually pops up is usually going to be Hashimoto's. So this starts to build my case. I look at what they mark on our checkoff sheet. Some people will actually put a question mark next to thyroid. They've been to the doctor and the doctor says, well, one day you have a sign you have Hashimoto's, one day you have a sign you don't have Hashimoto's. I'm giving you the medication, we don't know what it is. But of course, you're looking for people to check off thyroid. The next thing that people usually check off is depression. You're going to understand the connection between depression and Hashimoto's before this video is over. And digestive bowel problems, a key. A lot of people don't mark down digestive bowel problems. I will always ask if it's not marked down, do you have digestive bowel problems? Because it's usually there. And it's usually a factor in perpetuating your immune response against your thyroid. And I'll say, well, do you have acid indigestion? You didn't put down anything. Do you have bloating? Do you have acid indigestion? Do you have gas? Oh yeah, but everybody has that. No, everybody doesn't have that. And these are things that could be affecting your thyroid, your Hashimoto's. And dizziness and vertigo, you're going to find that dizziness and vertigo. And if this is the presentation I see and patients aren't marking anything else out, Again, it's building my understanding of this is going to be a good client, this is going to be a good patient, this is a person who's going to respond well to what we do because they have Hashimoto's. A lot of patients are going to mark down fibromyalgia. Hashimoto's is one of the main causes of the pain in fibromyalgia. Now, you don't have to have fibromyalgia, but if a patient marks it down or puts a question mark next to it, I'm going over with you the common history that I see in 90% of Hashimoto's patients or better. And so I'm trying to help you to kind of figure this out yourself as you're sitting there. I look for viruses. As you're going to find, viruses are a significant factor in the development of fibromyalgia. If you remember, I said I got mononucleosis when I was 21. At 21, I got a virus. I got fatigued. I had the fatigue for almost 14 months. I now understand that if you have it for more than 6 weeks, the possibility or probability of you having developed fibromyalgia from the Epstein-Barr virus attack is significant. And I probably had Epstein-Barr virus attack me. I probably had a low-grade Hashimoto's from the time I was 21 until I became affected when I was like 48 or 50 or something like that. So I look for high blood pressure because that's an indication of stress hormones flying through the system. I look for fatigue. In our office, if you come in here for fatigue, now a lot of people come in here with other conditions like fatigue and fibromyalgia, and then we have to inform them they have Hashimotos Thyroiditis or Hashimoto's, some form of Hashimoto's. And so if they have fatigue, somebody comes in here with that, we're going to think thyroid, blood sugar, stress hormones, gut, Epstein-Barr virus, anemia. Thyroid's number one. If they have fatigue, that's one more thing that's building to where I'm able to communicate to the patient on the level of, here's the symptoms, you have them, this is what's contributing to your fatigue, this is what's contributing to a number of different things here. I'm building my understanding of their case to determine at the initial consultation, do you have it, how severe is it, is this something we're going to be able to help? Cold hands and feet is another thing. That can be stress responses, that can be thyroid. It can be other things, but the stress responses and the thyroid primarily are what walk in here. A history of thyroid in your family. A history of autoimmune problems in your family. As I stated, I had mom, aunt, grandmother, all had goiters. 2 of them had their thyroid out. MS in my family, Parkinson's in my family. So I had a genetic propensity, an unexpressed gene that could be turned on to create an autoimmune attack against several things in my system, but in this particular case, the Hashimoto's. And then we go over, then I go over things such as eating habits, what makes you feel better. Well, some foods that I eat don't make me feel better. So what are those foods? Well, if I eat bread, or if I eat pasta, or if I eat rice, sometimes it's broccoli, you know? I mean, it just depends on what it is, but depending on what it is, it's more than just gluten. Most people kind of have the understanding now that gluten has something to do with Hashimoto's. You'll find out what here in a few minutes. But it's more than that. It could be, at certain points in a case of Hashimoto's, it can be anything. It can be any type of a food sensitivity that can flare things up. I try to, and then I look at their, you know, do they smoke, do they do alcohol, do they do caffeine? But another big thing is, can you sleep? Are you sleeping? There's two things, there's more things than this, but there's 2 things that we see all the time that create a scenario in which a patient can't go to sleep, they wake up, they can't go back to sleep. Probably most commonly, it's the stress response. It's an overfiring brain, and Dr. Gates is going to go into that in great detail in a few minutes. The inflammation from that stress response is a significant driver of Hashimoto's in many ways, and Dr. Gates is going to get more specific with that. But Hashimotos Thyroiditis, when it is under attack, can also cause you to not be able to go to sleep and wake up and not go back to sleep. And so again, we're gathering data, and by the time we get to the point where you have like 18 out of 20 symptoms of Hashimoto's thyroiditis, by the time we've gone through your history, then I feel confident in having the patient evaluated, because there are certain things in addressing chronic pain that we have had to come to understand acutely. One of them is autoimmunity, one of them is the gut, one of them is the fight-flight response, the stress response, the emotional trauma response, and the other one is the thyroid. And you're going to find out why here when we start to go over and fill in the specifics of what this all means to you as the suffering Hashimoto's patient, who is probably not getting any answers, or you wouldn't be watching this video. So what do you think? Is
Yeah, I think that pretty well
I
covers it.
know?
No, I think that pretty well covers it.
Okay, that
lays out the landscape.
that is the framework of what I experience, probably at least 5 times a week or more in this office when I'm doing consultation on a chronic pain patient. And I think it's very representative of what you should have been expecting from anybody that you've talked to up until this point in time. And if not, I hope this already is giving you a better idea of what's going on with you relative to your diagnosis of Hashimoto's thyroiditis. All right, let's go on to the exam room where we do the rest of our presentation, and you'll get to have the blanks filled in on so many of the things that we just got done saying. And again, I just know that this is so huge. This is such a core to the great autoimmune population that's developing out there. And I think you, as most of our patients, are going to find that you're extremely well informed once we're done with this next segment relative to Hashimoto's thyroiditis, and I'll probably give you a much better ability to converse with this with your physicians and kind of understand the things that you should pursue, and kind of be able to like look at the internet and maybe look at it with a little bit more clarity, and I'm very excited about that. And again, Dr. Gates, as part of this presentation, is going to go a long way towards helping to accomplish that. So now you've seen what a classic history taking should be for a Hashimoto's patient. All the entities that could be involved, all the things that point to, yes, you have Hashimoto's. And in our particular case, yes, you would be a good candidate to proceed with the exam procedures. In the exam procedures, Dr. Gates and I do the exam together. Dr. Gates does the lion's share of the exam. And frankly, the lion's share of that exam is directed towards the brain and the nervous system. That may surprise you. It won't by the time we're done. And then we check your thyroid, we check your gut, we check a lot of different things. When it comes to treatment, Dr. Gates is the treating doctor here, and Dr. Gates pulls the neurology aspects of what's causing and perpetuating Hashimoto's together with the functional medicine. Dr. Gates also is responsible for the reason we're doing these videos, in my opinion, because even though my mentor is the guy, Dr. Karazian, I believe I give him the credit for the fact that you may have even heard of the term functional medicine, but he exploded the thyroid, understanding that it was a significant part of all chronic pain and that almost all thyroid was actually Hashimoto's thyroiditis. But Dr. Gates also has taken an enormous amount of time to review, I'm not exaggerating when I say thousands and thousands and thousands of peer-reviewed journal references from all fields related to the history that we just got done talking about, to help to understand and fine-tune an approach towards Hashimoto's thyroiditis, because it's such a key to so many of the things that we treat: dizziness, vertigo, balance, migraine, gut problems, fibromyalgia, chronic fatigue, and so on and so forth. So Dr. Gates has decided to present this in a way that delineates how the 3 models go through this. There's a medical model of management, there's an alternative model of management, which would include your alternative medical doctor as well as maybe your alternative functional medicine doctor. And then there is the kind of functional medical medicine and functional neurological model. And then he's going to wrap up with some of these other associated conditions. So he's going to start with the medical model and how the medical model presents, because that's where most of you start. So.
Yeah, so with the medical model, it's just very important that you understand your blood tests and how we discuss the thyroid, because when you go to your medical doctor, they're going to be looking at a value called TSH. TSH you may have seen on your lab test. TSH is a hormone that comes from your brain to your thyroid, telling your thyroid to make thyroid hormone. It's called thyroid stimulating hormone, hence TSH. Your thyroid makes inactive thyroid hormone, T4, which then circulates throughout your body and primarily is converted into active thyroid hormone in your intestines and your liver. Simply, if your TSH is elevated, your doctor is going to tell you that you have hypothyroidism. Now, it's important to know that many doctors are trained differently depending on largely the era that they were trained in, where to treat your thyroid based on the TSH value. By that I mean, the high value for the TSH is usually somewhere around 4.5. A lot of doctors are trained not to give you a thyroid medication until you're around 7 or 8. Whereas there's new data coming out saying that maybe even people above 3.7 need a thyroid medication. There are studies coming out on pregnant females saying that anything over 3 is possibly the criteria we need to use for giving a medication. Or even there's a study out of Korea that said a TSH over 2.85 is indicative of hypothyroidism. So if you're reading thyroid books or you're looking online, a lot of functional doctors, alternative doctors will say a TSH over 3 is a problem. Just so you know, that's where that information is coming from. Usually in the medical world, they're going to give you a T4 based medication, meaning it's going to be an inactive thyroid hormone medication like Synthroid or levothyroxine, and they're going to depend on your body to convert that levothyroxine or Synthroid into the active form of T3. It's interesting because more recently patients are asking their doctors to test for T3. Before that, we saw in reviewing labs that commonly T3 wasn't even tested for, largely because when you have a diagnosis of hypothyroidism, the insurance companies will dictate to your doctors that they're really only allowed to check a TSH or T4, and the whole T3 issue is becoming more of a new phenomenon. That's the mainstream medical model. If you ask your doctor, why do I have a thyroid condition, or why do I have Hashimoto's, they'll probably tell you, there's a genetic association that's really hammered. But as we'll discuss later on in this broadcast, why is the incidence and prevalence of Hashimoto's exploding? So it's upwards of 1 out of 3 females now are indicated to have Hashimoto's according to some new research. And so this autoimmune problem, not only involving Hashimoto's, but other conditions, it's just a ballooning phenomena that we have to account for. And we're going to talk about that later on. But that's basically the medical model and how they manage the thyroid.
So I'm going to ask you a question by the look on my face, right?
Yeah.
So I'm going to throw you maybe not so much of a curveball, but it's interesting, doing the consults, I get to kind of get a feel for where the flow is going in the alternative medical world, so on any particular condition, because years ago, patients didn't even know they had Hashimoto's. You had to convince them. Then it was, I have Hashimoto's, do you have like an herb for it? And then it was, I have Hashimoto's, what do you guys actually do, because nothing else is working. Today what I'm hearing is, today we're seeing a lot of thyroids come out. Mm-hmm. I mean, like, thyroid to me is like the new gallbladder. Mm-hmm. We are having a lot of patients come in, particularly just recently, literally within the last couple of months. I'm hearing from their doctors, well, the antibodies are going to kill your thyroid and there's nothing we can do about it, so we're just going to let the antibodies kill your thyroid. And usually that's all they say. They don't say, then we're going to like manage it with thyroid hormone or anything. A lot of people getting radiated, a lot of people having thyroids out. What's your observation on that?
Well, the first observation is that when I came into clinical practice in 2009, at that time, Hashimoto's was hardly ever discussed. It was hardly ever tested for. Maybe you would see an endocrinologist test for it, but otherwise in the GP community, internist community, OBGYN community, you weren't really seeing Hashimoto's tested for. And people like Dr. Karazian then started this movement. We were checking for it, but no one else really was. So now there's a lot of buzz out there about Hashimoto's and thyroid disorders. There are a lot of support groups. There are a lot of books that are pretty popularized now, including Dr. K's book. So because of that, more GPs are feeling the pressure to test for the antibodies, which is the thyroid peroxidase antibody and the antithyroglobulin antibody when it comes to Hashimoto's. And so doctors are checking for these antibodies, and then patients will ask their doctor, okay, well, these antibodies are positive. I'm confirmed for having Hashimoto's. What is the treatment? In the medical model, we've talked about the Mayo Clinic communiques that come out. There really is no different treatment for Hashimoto's that's widely accepted now, except just watch and wait. So if your thyroid tests are normal, and you're not on a thyroid medication, they may just say, well, we'll wait till your thyroid dies until you need a medication. If you have the need for a medication, you're on a medication, you have Hashimoto's, they're going to say, well, we're still going to give you the thyroid medication. That's pretty much what we see out there. That's the model.
And I mean, I think it's, maybe I'm putting you on a spot here, like relevant to maybe address the abnormal cells that some of these patients have in their biopsies.
Yeah,
that
thank you for redirecting me to that. I missed that. So within thyroid, and we see a lot of thyroid patients too, so we run thyroid ultrasounds often. We refer patients for fine needle aspirations of the thyroid, because no matter what your treatment is, whether you're talking about a nutritional treatment or an herb treatment or a medication treatment, you have to identify the pathology. And so when patients have swelling or they're reporting a nodule in their thyroid, you send them for an ultrasound. Frequently, then that leads to an aspiration, a fine needle aspiration of the nodule. If the nodule is basically over 1 centimeter in its characteristics. And the fine needle aspiration results commonly come back saying no dysplastic cells were observed. However, we cannot account for other areas of the nodule that were not biopsied. So based on that, that can create a lot of tension for a patient, because the patient is thinking, okay, well, it's not definitive. And so often these fine needle aspirations, it just can't be definitive, because it's really hard to take fluid out of each part of this nodule. And you have to also consider the medical legal climate that doctors are practicing in today. And so, for example, if you have a fine needle aspiration and there are no signs of cancer, but the the pathologist doesn't say, we didn't get all the margins, so to speak, here, and then you end up developing thyroid cancer, then you could come back and create a problem for that pathologist or whoever the thyroid surgeon is. So because of that, my inference is that is why so often patients with these thyroid issues and these maybe abnormal cells, maybe not, just elect to have either half of their thyroid taken out or their entire thyroid taken out and told, okay, well, you'll be fine, we're just going to put you on thyroid medication. As we go through this discussion, we'll talk about how even if that does happen, the underlying cause of the problem is still not being remedied. And we have a lot of patients who come in here who have had thyroidectomies and they still have a ton of thyroid symptoms, and it begs the question why, and we'll talk about that.
And we call this the B.S. series to get your attention, but what we're really doing here is trying to really filter through all of the things that you just got done hearing about. The medical legal system has a lot to do with why you're getting those thyroids taken out. Some of the insurance codes can have something to do with it. It's just the model right now it's not the best model. The medical model is not the best model for a lot of chronic problems, because it's really an acute care model. Give it a drug, take it out, do the surgery, give it a drug, things of that nature. We're not anti-medicine. We're going to go on to the alternative model now. I actually don't feel we're alternative. We rely heavily on the research from the medical field. We rely heavily on classic medical diagnosis. We rely heavily on mostly classic medical lab technologies. We use some of the alternative, if you will, testing, but nowhere near as much as you might experience from some of the models you're about to hear about. When it comes to treatment, I'd say we're largely alternative, but we have kind of a bell curve of our patients, where most of our patients can get through these things without drugs, and then there's kind of a little slice off the end there that may need some therapy. They may need a thyroid medication, or they need some sort of other medication, in which cases we will be attentive to the pathological aspects of a case and work with the medical doctor on that. So I think, we're not promoting, we're not dissing, we're not being dismissive or insulting to the medical model. Mm-hmm. We're just telling you the way that the research says that it is, and we're seeing that that is the way that it is in clinical practice. Mm-hmm. So we're sharing that with you, the alternative model.
Probably the strength of the alternative model from the patient's perspective is that now there's so much focus on T3. There's even a nationally known doctor who's kind of a thyroid expert who talks about you need T3, you gotta have T3, you gotta have T3. And so based on that, a lot of patients have gone to their GPs and said, I want T3, and the GP is like, no, I'm not giving you T3. If you want T3, you need to go to an endocrinologist. So often then the patient goes to the endocrinologist, maybe they're given a little T3, maybe they're not. And so out of that, this group of integrative or alternative doctors have kind of blossomed with a lot of focus on T3-based therapies. Now, we work in an integrated fashion with other doctors, so we would refer patients when we saw low T3 values. What we can say is that, yes, this can help We've seen it work with some of our patients. We have not found this to be the major linchpin. And frequently when patients go into an integrative medical facility, a functional medicine medical doctor, functional medicine DO, functional medicine nurse practitioner, someone like that, they're going to talk about these T3-based medications, maybe bioidentical, maybe something like Armour thyroid or Nature thyroid or WP thyroid, all these basically animal thyroid derivatives because the animal thyroids have T4 and T3 in them. The issue we've seen relatively commonly with these animal-based thyroids is that if you have a hypothyroid condition, you have a 95% probability of having Hashimoto's, according to LabCorp. Some statistics are more like 70%, but the probabilities are pretty high. And so if you have an immune condition where your immune system is killing your thyroid, and now you're taking an animal thyroid, there's a probability that your immune system is going to attack the animal thyroid and inflame your Hashimoto's response. And there are journal articles saying, that we'll get into later, but that state, and this is really important, that Hashimoto's, independent of your thyroid hormones, can cause all the same thyroid symptoms, which is pretty profound, in that you have to understand that, yes, the thyroid hormones are important, but what everybody is missing, like 90% of the pie in our opinion, is this Hashimoto's response, where you have this autoimmune condition. And the analogy would be, if you had rheumatoid arthritis, everybody knows rheumatoid arthritis, at least most people know, is an autoimmune condition. And we don't have a medical treatment where we just replace the joint cartilage, because first of all, that's not possible. But that would be an analogous model to the thyroid, where with the thyroid, the immune system is killing the thyroid, so we give you more thyroid hormone, but nobody's paying attention, or at least most people are not paying attention. There's not a lot of publicity about this, that the issue is really your immune system. So that's what we found. And then if you do go into an integrative practice, what we commonly find is that patients are recommended to have heavy metal testing. They're recommended to have this heavy metal testing because the doctors will then tell you that, well, if you have heavy metals, this can cause autoimmune diseases. Just for perspective, if we're going to cut through the BS, while that can be true, most of those studies came from miners in South America, where when they did the studies, their regulations, so to speak, on not being exposed to heavy chemicals are not like they are here.
Right.
So, I mean, these are people with their hands in vats of mercury and things of that nature. So these people developed heavy metal toxicity, and they had a higher incidence of autoimmune disease. Meanwhile, then we do tests here in the United States done by a lot of integrative doctors, and we did them for a while too, and pretty much everybody comes up having some form of heavy metal exposure. And so the question is begged, if we have a group of Hashimoto's patients going through our treatment facility and we're not even attending to the heavy metals because everybody seems to have them, and we have patients getting better doing what we're doing, how important are the heavy metals? And it's just an important point because these heavy metal chelation programs are not cheap. They're rather expensive. And if you want to look up some of our broadcasts on this, you can look it up online. There's a great debate. There's a pretty widespread dichotomy or diametrically opposed opinions between really the mainstream medical community and the functional medicine medical doctors and DOs on this issue, but that's kind of the background research there. So if you do go to an alternative doctor, that's probably something you're going to hear about. Now, I'm not saying that chelation has never helped anyone. We've seen it help some people.
Oh, absolutely.
We absolutely have. We saw it save one individual's life who had a lead poisoning occurrence that was causing, what were you going to say?
No, you go ahead.
That was causing Hashimoto's and fibromyalgia. But to say that it's the cause of all of these conditions, we feel is not entirely accurate based on the current data and the patients that we've seen.
I think the metals is representative of a lot of the things that we had to sift our way through, which is a lot of doctors today are not taught to critically think. I mean, I don't know how else to say it. It sounds impolite, but so they defer to the test, go to a seminar, here's a test I can use. And then that's one more thing that I can do, because they don't do a history.
And I'm going to pause you on that. And Dr. Rutherford's more referring to the integrative doctors.
The integrative doctors,
He's not referring to the standard medical community.
No. Yeah. Yes, thank you for clearing that up. So basically what happens is they keep collecting these tests. Now down the new thing is this genetic testing. They do all these tests and then they treat according to tests. That's not what happens here. But we had to sift through heavy metals, and as Dr. Gates said, we had profound change in that one patient he's talking about. But this is the same thing with parasites. It's the same thing with colloidal silver. It's the same thing with candida. A lot of the doctors tend to cling to a one silver bullet diagnosis fits all. Maybe they had somebody get a parasite out of their system. Maybe that calmed down their gut and their immune system, and maybe the person had a great response. Maybe the person got off of gluten, and all of a sudden they could walk and their balance went away. So now they tried it on everybody. We had to understand that each of these has validity in specific cases, and that we had to create an understanding, a history, and an exam procedure that would tell us when and when not to look for those in individual patients. So speaking of that, how about selenium, iodine, and gluten?
Oh goodness. So
these are the big, the iodine's huge, it's a big controversial thing, selenium, gluten.
Yeah, so for you to make inactive thyroid hormone, you have to combine hydrogen peroxide with iodine to make T4. That's how it works. The thyroid peroxidase enzyme in your thyroid does that conversion. Now I mentioned before the thyroid peroxidase antibody. So most of you who have Hashimoto's have high thyroid peroxidase antibodies, which is killing the thyroid peroxidase enzyme that takes iodine and hydrogen peroxide and makes T4. So one of the original thoughts, and Dr. Karazian I think really kind of fronted this, was so in the alternative community there's a lot of talk about taking iodine because your thyroid needs iodine. Well, if you're taking more iodine, and the reason why you have a low thyroid is that you have Hashimoto's, are you actually inflaming the response? And there is a lot of research in the literature regarding this, about case study after case study of individual coming to the emergency room after taking kelp-based supplements or iodine-based supplements for their thyroid and actually inducing a state of hyperthyroidism or frank hypothyroidism that was even worse, provoking Hashimoto's. So we caution anybody who really wants to take iodine for the thyroid. Now, the whole thing with the iodine and the thyroid came about mainly in the 1940s to 60s in the Midwest, where the soil was depleted of iodine. So you had people pretty much growing agriculture, living off the land, never getting exposed to any iodine, and because of that they developed goiters because their body was deficient. However, now all of our table salt for the most part is iodized. So you're gonna get your recommended daily allowance of iodine even by consuming a small amount of table salt. So from that, most of us don't have iodine deficiencies. If you are really curious about it, you can get tested for it, but we have not found this to be a very successful treatment outcome, and frankly it's pretty dangerous. We've seen it not work. A lot of people are taking iodoral and other things, and other iodine-based supplements. Now relative to selenium, selenium absolutely has a role in modulating glutathione. It's important involving the thyroid. We've used selenium-based supplements, and frankly we never really saw a difference. So there's a lot of talk about it.
There's so many other things going on.
There's so many other things going on, and you have to realize, when Dr. Rutherford mentions that I've read thousands of research articles, I read these research articles and then we put them into practice and we see, okay, does taking this supplement with this supplement actually produce a clinically successful outcome? And so often the case is not. And so that's what you have to realize. Even if there is research there, you have to see if it actually works. And we have not found the selenium phenomena to work. Do certain pesticides maybe deplete the body of selenium? Probably. But this is not the whole enchilada. And the last piece was gluten. So you're going to see a lot of information. Everybody's now talking about gluten as it comes to the thyroid. We'll talk about this more in detail as I talk about our approaches. Gluten is important. Are other foods important in our experience? Yeah. Just the research is early. In 50 years, you're probably going to see at least 10 to 20 foods discussed as being involved with Hashimoto's, most likely. But that research is just not being done now because it's so early on.
Yeah, and then figuring out what your food sensitivities are is another whole ball game, as most of the food allergy tests out there, according to Dr. Ari Vajdani, one of the top immunologists in the world, and the developer and founder of Cyrex Labs, are inconsistent and unreliable. The testing is inconsistent and unreliable, and I assume it's because so many of these people have autoimmune problems and they got chronic stress hormones. But if you've been told you have 56 different food sensitivities, you probably don't. You probably have an autoimmune problem. Maybe we'll get into that a little bit, or no?
Yeah, why don't I just go into that right now?
Are you going to go to the functional medicine?
Yeah.
Okay,
yeah.
So now we're going to go to the functional medicine and functional neurology model, which is the model that we have put together here and don't really have a name for it, although we've had a lot of our viewers suggest names for it, like the integrated systems approach and these types of things. But this is what we found we had to do. The alternative model was having success, but it was sporadic. The functional medicine model neurology model was looking at dizziness, vertigo, balance, migraines, chronic stress responses. They probably, weren't getting the results that they could have gotten if they were doing the proper chemistry for the brain. We weren't getting the results that we should have been getting if we started looking at the chemistry of the brain, but more the stress hormones that are being put out of the brain, and thus the realization melded these two disciplines to a pretty consistently successful result, again, in properly selected patients. So the functional medicine and functional neurology model, which is the one that we use.
There's a number of directions I want to go there, but I think I'll just start with the gut. Well, I mean, it's interesting because just so you guys, just so all of you understand our story, really, Dr. Rutherford got involved.
He's been hanging around me too much. I'm from New Jersey. It's like you guys.
Just so the viewers can understand that Dr. Rutherford got involved with functional medicine fairly early on. My training was to become a board-certified chiropractic neurologist. That's referred to as functional neurology. That involves a lot of brain rehabilitation exercises, stimulation techniques for people with chronic neurological disorders like MS or Parkinson's or vertigo conditions or migraines. Now, early on, we tried doing just functional neurology-based techniques, and we had some success, but they were not long-lived. Then we went through a whole period where we just did functional medicine, which involved a lot of dietary approaches, autoimmune approaches, supplements, and we had good results, but they weren't long-lived. And so that's where we've come back to integrating our two models, and we've come up kind of with a new paradigm, as Dr. Rutherford is saying, within functional medicine and functional neurology to approach these issues. Now let's start with the gut. So in the gut, Journal of Thyroid, I believe the year was 2008, they found a high incidence between gluten-mediated reactions in the gut and thyroid antibodies. There was some discussion of this beforehand where they started seeing a lot of patients who had type 1 diabetes and celiac disease also had Hashimoto's Thyroiditis. So that prompted this investigation. At that point when this article came out, it was kind of like all bets were off and everybody was running on the whole gluten phenomena. Now the whole gluten phenomena at that point, in 2008, there weren't a lot of gluten-free products. So if you told somebody to go off gluten, they were pretty much eating meats, vegetables, and fruit, which eliminated a lot of these other foods that are now in these gluten-free products. And as Dr. Rutherford can attest, a lot of people had these miraculous changes going off of wheat. And that was fantastic. And the reason why is through a mechanism called molecular mimicry. So if your immune system is attacking the gluten molecule, if the gluten molecule looks like your thyroid, then the immune cells to the gluten can then attack the thyroid.
And the gluten molecule looks like your thyroid.
Right, and we're finding that then these thyroid antibodies can kill a variety of other tissues in your body, and they may be associated with other antibodies that kill other parts of your body, if that's not complicated enough. So we're now finding, just as to allude to it, we're finding these immune cells of the thyroid can attack the cerebellum. We're finding they can attack vestibular nerves. We're finding that they can affect blood flow in the frontal lobes, on and on. We'll talk about that more. So the gut seemed to have a major importance in involving the thyroid and Hashimoto's. So from there, doctors started doing more food sensitivity testing, experimenting with patients, and finding that it probably wasn't just gluten. There may be upwards of 10 or 20 other foods. Even products like latex in some circles are thought to involve this Hashimoto's response coming from the gut, because if your immune system is making antibodies here, it's going to make antibodies to your thyroid. And as Dr. Rutherford said about the food allergy testing being inaccurate, we have a lot of patients coming here with food allergy tests, and a lot of them are just frankly frightened by their food allergy testing that they have so many problems. What you have to realize is that immunology is pretty complicated, and if you have a food allergy test, that's looking most likely at an IgE response. That's a certain type of immune antibody and an allergic response, whereas some of the stuff that we're talking about are more sustained immunological responses that can take 24 to 72 hours to develop. So somebody may eat gluten and they may not feel bad initially, but they may feel bad 2 to 3 days later. And it may not just be gluten, it may be another food. So the gut has a lot of importance. Then the question became, with the gut, why are food molecules getting through the intestines? We have intestines that should be like a barrier. Think of a PVC pipe that shouldn't allow these big macromolecules through, and that brought up this whole phenomena of leaky gut. Now, leaky gut is a horrible term. We don't like the term. We actually don't even like to use the term, but we have to use the term because it's widely acknowledged in the literature now. And if you go on Wikipedia and you read about leaky gut, they're going to say it's a bunch of hooey and that it doesn't have any validity. And you can go on Power Health Talk and watch our broadcast on leaky gut where we attached, I believe it was over 100 references. I think it was like 110 references validating leaky gut as it relates to so many different conditions. So leaky gut and the microbiome, which is the bacteria in your intestines, really is a huge topic of discussion. Harvard Medical School is working on it. A lot of different research facilities are working on it. So just know the validity is there. And this is an important piece of Hashimoto's because what they're finding is that when the intestines are excessively permeable and food molecules are getting through or big protein molecules are getting through that your immune system is then recognizing like a bacteria or a virus, we get this overactivation of immune cells to the gut, and then the overactivation of immune cells kind of deprives maybe the rest of your body for attacking other things. The reason why this is important moving on is that in 2012, a landmark study came out showing that 80% of Hashimoto's patients have a certain type of herpes virus living in their thyroid. And when they compared the Hashimoto's patients to normal people who don't have Hashimoto's, they found a huge association where the normal individuals didn't have the virus in their thyroid. Then in 2015, a large article out of the journal Endocrinology Poland, I believe, showed that Epstein-Barr virus was present in 80% of Hashimoto's patients' thyroids. And then other viruses like Vibrio viruses have been found in the thyroid of Hashimoto's patients. So it's a big, big deal. So this kind of raises the question of chicken or the egg in the quest to get to the underlying cause as to why your immune system is attacking your thyroid. Some thoughts are that people are genetically susceptible for Epstein-Barr virus to live in the thyroid. And because of that, then one side of the immune system gets overactive and tries to kill the thyroid, trying to get to the Epstein-Barr because the other side is incompetent. Think of playing whack-a-mole. The other thought process is that there's so much immune activation at the gastrointestinal immune interface that allows then one side of your immune system to be kind of blind and not see the virus living in the thyroid, and then the other side will get overactive and kill the thyroid. There are other lines of thought that there's excessive inflammation in the body, and that when there is excessive inflammation, the thyroid will actually attract immune cells to it to kill it. And it's thought that a lot of this inflammation is coming from the gastrointestinal tract. Now, when you're out in the world of the internet, you're going to see Dr. So-and-so and this doctor and that doctor's leaky gut protocol. And we've done a lot of those protocols, and we have our own leaky gut protocols. But what we have found to be the missing feature of leaky gut management is the stress response. So many patients come in here who are in a chronically activated state of fight or flight. And when you ask them, are you stressed? They'll inevitably say, I'm not stressed. I'm not stressed. Because it's almost like a personality weakness for us to say if we are stressed.
Or they might be at a point in their life where their life is calm.
Right.
But they still can't understand that these symptoms that they're having is coming from a traumatic stress, as Dr. Gates is going to explain in the past.
Exactly. And so we find that a lot of our patients have been through some pretty traumatic experiences, especially in childhood. What they're seeing is that when an individual is exposed to trauma, whether it be seeing a loved one die right in front of you, consistent forms of abuse, or even just isolated forms of abuse, physical, sexual, emotional, that when this happens, it can prime our fear center in the brain, it's termed the amygdala, to become overactivated. And when this amygdala becomes overactivated, then it tends to secrete too much cortisol, which then can feed back and damage the intestinal lining, can feed back and damage the frontal lobes as well as the memory area of the brain. The frontal lobes and your memory area try to keep this fear center in check. So it's like you get an evil dictator that comes about. And this is why when we see the literature on the trauma earlier in life, it predisposes people to depression, like significantly depression, anxiety, irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome. And because there's such an overlap with fibromyalgia and Hashimoto's, which we'll talk about in a little bit, we've seen a large correlation between this too and the Hashimoto's. We've also seen significant correlations between Hashimoto's and surgeries. We've seen other correlations between Hashimoto's and other stressors. We've also seen it where an individual has a viral infection with herpes on their mouth and then they get Hashimoto's. Really, you have to, as a clinician, if you're practicing functional medicine or functional neurology, you have to be that investigator, that detective, to figure out what was that preceding incident that may have instigated an individual's Hashimoto's response. So that's really, really important. Genetics can play into it, but as I alluded to earlier, genetics don't account for why we have this burgeoning autoimmune problem. So that's also important. And was there anything else on that list that I was going to go into?
No, so, and to pull a couple of nuggets out of there just to make it clear, the 3 causes that we know of that create Hashimoto's, for sure. Dr. Gates went over a lot of literature. He mentioned some other things, is viruses, stress hormones, and gluten. And it's an ongoing evolution and understanding of what's going on. And he mentioned, so you start looking around and going back, did I get a viral infection? You know, for me, I got Epstein-Barr virus and probably had low-grade Hashimoto's for years. That's another whole thing we could go into, is how some people just blow up. Some people, it's a continuum forever. It can be very confusing. If you don't understand the full breadth of Hashimoto's, it can be very confusing to diagnose, particularly if your antibodies come up negative. If your antibodies come up negative, which is what you test for Hashimoto's, it doesn't mean you don't have it. If you have like 20 out of 20 symptoms of it and your antibodies are normal, you probably have it. So now this gets us to like the last section, and this really kind of is the section that I'm most excited about. And I was tempted to name some of those doctors that are online that are selling their supplements. Take our supplements and you'll just take them and then it'll fix them. By the way, if you have Hashimoto's thyroiditis, you might be one of those that I hear in the consult. You know, I take drugs, I take supplements, I eat food, and everything I react to. Less of everything is more for you. Less exercise is better for you. Less supplements is better for you. Less drugs are better for you because you have an autoimmune problem. You have stress hormones flying around. Your system is sensitive to a lot of things, and the system is very complex, your system. And we don't know everything we need to know about it yet. And the less you can put in there and get a maximum result, the better. And that leads to other associated conditions and symptoms. And I think this has been the exciting part of what you've brought to our practice in Dr. Gates's research, because it's given us such a step up on the ability to not just diagnose Hashimoto's thyroiditis, but to diagnose that overall patient that comes in here with a list of 15 drugs or 10 drugs, and they've been to 26 doctors, and they have gut problems, and they can't have a child, and they can't lose weight, and they have brain fog, and they got dizziness and vertigo and balance, and so on and so forth. And they've been to the neurologist, and they've been to the birth control people, and they've been to the people for fertility drugs, and they've been to the people for their gut. And this patient's thinking like, my God, where is this going? And it turns out, if you have Hashimoto's, that is the classic canary in the coal mine. And here's what we mean by that.
And I'm just going to hit a few points before I jump into that.
Go.
So for all of you who may be trying to go gluten-free, and again, gluten is just the tip of the iceberg, but a journal article came out, Gastroenterology 2015, where they looked at non-celiac gluten sensitivity, which are
huge.
Those of you who eat gluten and you feel worse, but you don't have celiac disease. And so many of you are being told now it's dangerous not to eat gluten because it may raise your incidence of heart disease. Yeah. I just heard that again yesterday. We did a whole broadcast on that, so go watch it on powerhealthtalk.com. But they found that like 29% of these individuals who have non-celiac gluten sensitivity have Hashimoto's. An even higher percentage of them had autoimmune responses. And
non-celiac gluten sensitivity, you eat gluten, it doesn't screw up your gut, you don't have celiac, but
you feel worse.
It creates more neurological and
typically
immune
they're more neurological responses. So you may have brain fog, you may have depression, you just generally don't feel well. You may have some
maybe your feet burn.
Exactly, side effects, maybe your feet burn,
maybe
on
you
and on.
lose your balance.
Yeah, and so that's really important. Also too, when you said less medications or more, we're not telling you not to take your medications.
Correct.
Just always be specific, because you want to believe the comments that we get.
Thank you.
Yeah, I just want to clear that up. Now when it comes to brain fog is one of the most interesting symptoms we deal with, because almost every patient that comes in here has brain fog.
Yeah.
And they just say, I'm in a cloud, I can't think, I can't retrieve my words. I see people I know, I can't remember their names. Yeah, I get confused. I can concentrate for 20 minutes, but then, I used to be able to read a book for 3 hours and now I can't do that. Why is this happening? Just know anytime somebody has brain fog, or if you have brain fog, there's immune inflammation. It's either allergic or autoimmune. That is what the research shows. What we're seeing with Hashimoto's patients that's really interesting is that when you have antibodies to the thyroid, they're now showing that these antibodies reduce blood flow significantly in the frontal lobes. This is why it's thought that Hashimoto's is associated with conditions like depression. If you go into a psychiatric facility, I know of 2 studies now that have been done on this. The estimates are pretty similar. They're finding that about 32% of individuals who are basically hospitalized for depression have Hashimoto's. 32%, that's a third of the people in there have Hashimoto's. And there's a clear mechanism as to why Hashimoto's is associated with depression. And these are people who have Hashimoto's and their thyroid hormones are not necessarily deranged. So it's specifically the Hashimoto's response. This autoimmune attack against your thyroid is also screwing up your brain. And we find commonly this is associated with brain fog. We also see in the literature that patients who have Hashimoto's have a variety of other antibodies to targets in your brain. That's how it's termed. So basically you're making other antibodies independent of your thyroid antibodies that are killing your brain. One of those antibodies, they're called ganglioside antibodies, which we see with celiac disease patients, we see it with gluten problems, we see it with Guillain-Barré patients. Just know that these antibodies seem to trace back to the gut and they may have a relationship to a Campylobacter infection in your gut. But it's very, very interesting because it seems like when people are consuming gluten, and most likely other foods, that are breaking down the intestinal lining, it's not only creating antibodies to your thyroid, but antibodies to gangliosides, which are part of your architecture of your brain. That's a big, big finding because I don't think most of you realize that maybe your immune system is killing your brain. And maybe that's why you're experiencing depression.
Yeah, and how many people do we just put on our baseline diet of allergies and their brain fog improves and, and stuff like that? And that's gut.
Yeah, and for years we had patients where their depression got better. And we have a lot of patients who have other more severe causes of depression that have to be addressed too. But this is an important finding. Now moving on, the associations between Hashimoto's and fertility, menstrual irregularity, heavy menstrual bleeding, facial hair are very, very interesting. So let's talk about polycystic ovarian syndrome. Polycystic ovarian syndrome is a condition where a female can get cysts on her ovaries. She may have abnormal menstrual cycle lengths, either too short or too long, very infrequent, and she may have excessive facial hair growth or thinning of hair on the top of her head or hair growth in other parts of her body that are unwanted. Now, polycystic ovarian syndrome can not only be significant from those perspectives, but it is also the most common cause of infertility in our country. And so the medical management of polycystic ovarian syndrome is to give these individuals birth control because they have too high of testosterone. So what they're trying to do is raise your estrogen and progesterone levels to normalize the ratios. And if someone wants to get pregnant who has PCOS and they're unsuccessful, then typically they're referred to a fertility specialist, and they may use other medications to try to get the ovaries to secrete more eggs and be more healthy. Now we're finding that there's a large correlation between Hashimoto's and polycystic ovarian syndrome. The research first came out showing that there seemed to be a subtle association. Then one study came out and found that 43% of individuals with polycystic ovarian syndrome have Hashimoto's. Then another study came out, I think it was from Buenos Aires, if I remember correctly, it might have been somewhere else, where they found a 5-fold increased probability of having Hashimoto's along with PCOS versus people who don't have PCOS. So there's a 5 times increased chance of having Hashimoto's if you have PCOS. And some people are now even referring to PCOS as an autoimmune condition because this association is so dramatically high. And it's thought that possibly the inflammation associated with the Hashimoto's leads to oxidation within the ovaries and a variety of other problems that can be problematic, and possibly the underlying mechanisms causing Hashimoto's, which we've talked about, dysregulation in the gastrointestinal tract. We also find that's common in PCOS patients because they have insulin resistance, they have prediabetes, and we're finding that these pre-diabetic and insulin responses are tied to leaky gut, and they also cause excessive production of testosterone for females, either from the adrenal glands or from the ovaries. So that's highly, highly, highly significant. So any patient that comes in here with PCOS, we talk to them and we screen them for Hashimoto's. Now moving on, Fibromyalgia, the infamous fibromyalgia. We have seen so many fibromyalgia patients. Fibromyalgia patients, if you don't know, are people who have just odd pains, that may be pain throughout their entire body, it may be pain that migrates around throughout their body. Commonly it's associated with brain fog, depression, possibly anxiety, poor sleep patterns, irritable bowel syndrome. And fibromyalgia patients present with fatigue as well. And we've been seeing this correlation between Hashimoto's and fibromyalgia since 2009. It really came out in the literature in 2014, Journal of Clinical Rheumatology. They documented this high association. And then in 2017, a really cool study was done where they took a group of Hashimoto's patients and they said, okay, how many of you have fibromyalgia? They found that 62% of Hashimoto's patients have fibromyalgia. So that means a large percentage of you out there watching who have Hashimoto's, you may be experiencing fibromyalgia symptoms. And we won't go into all the details on fibromyalgia, but Hashimoto's is a major player with that condition for every reason that I've already explained and that we've explained. Because
we have a number of presentations
on it that's going to be associated with brain fog and fatigue, etc. So that's significant. Then we have neurological conditions and vestibular conditions like Meniere's disease. Meniere's disease is a condition where people get vertigo. It's an awful condition where the vertigo can last for hours, sometimes days, where the room is just spinning around people. They frequently will just be vomiting constantly because the vertigo is so disabling. If they don't respond to traditional diuretic therapies and reducing salt, then frequently they're told, okay, you have to have like your inner ear cut out, or we have to go in and cut the nerve involving the inner ear. There's now a lot of research showing that Meniere's disease is either an autoimmune or allergic condition, and more recently they found a demonstrable association between Hashimoto's and Meniere's disease. So it's rather significant. I think it was upwards of 2/3 of Meniere's patients had thyroid antibodies. And the thought process is you can go and Google vestibular anatomy. Our inner ear has a lot of fluid in it, and that's how we sense rotation, and that's how we hear sounds. What they're finding is that the duct that drains that fluid seems to get clogged by the immune inflammation, and now the thought process is that potentially it's the antibodies to the thyroid and all the inflammation associated with that that's clogging that duct that may be associated with Meniere's disease. So that's a big condition. We've even had other patients email us who are going to Johns Hopkins who had balance conditions, and they may not have had vertigo, but they had dizziness. And there's even research now coming out showing that these antibodies to the thyroid kill the vestibular nerve. They found that I think it was upwards of 44 or 48% of Hashimoto's patients have vestibular nerve damage. So if your balance isn't the best, or if you have dizziness, you have to consider this as a potentiality with Hashimoto's.
No cerebellum.
Oh yeah, well, I already alluded to it. And then you put on top of that the fact that so many of the patients we see, their antibodies to their thyroid can have cross-reactivity to the cerebellum. So you put an individual through cerebellar tests and they completely fail. You put
cerebellum, dizziness, vertigo, balance, stiff neck, blurred vision.
Poor coordination, you're clumsy. Yesterday, we have patients, we put them on a foam surface and they can't even stand on there when they have Hashimoto's. And when you run further diagnostic testing, other antibody tests, you find that their immune system looks like it's attacking the cerebellum too. So that's a really important detail. Peripheral neuropathy is a condition where people get numbness, tingling, burning in their feet. There's a large association between peripheral neuropathy and hypothyroidism, but going back to the ganglioside argument, gangliosides are involved in peripheral nerve tissue as well. And so part of the thought process is now if you have Hashimoto's, because we see a lot of patients who come in with peripheral neuropathy and they have Hashimoto's, which in the literature, in the textbooks, is referred to as a dysimmune condition. So they have a dysimmune neuropathy. Really, they have a Hashimoto's neuropathy and their immune system is attacking their peripheral nerve tissue. And the last one is inability to lose weight. We have a lot of patients come in here who have never been able to lose weight, or they're not able to lose weight and keep it off. Just going back, again, I referenced before that there is research showing that patients with Hashimoto's, independent of their thyroid hormones, will have inability to lose weight and a variety of other thyroid symptoms because of the inflammation associated with Hashimoto's. So that's really important too. And also when people have Hashimoto's and other thyroid conditions, they're more prone to be insulin resistant, they're more prone to have non-alcoholic fatty liver disease, the liver just doesn't process things as fast, so that can be implicated as well. And just in our clinical experience, we see a lot of crossover between insulin resistance and Hashimoto's because of this gastrointestinal related dysfunction. Anything I missed you can think of?
You don't want to know. Migraines?
Yeah, migraines. I thought you were going to bring that up. Yeah. So relative to migraines, there's now a lot of research coming out showing that autoimmune problems can be a provoking factor for migraines, including that we're talking about Hashimoto's. When you have a migraine, basically a migraine, think of dropping a rock in a pond and you get the spreading waves within the pond. That same phenomena happens when you have a migraine. Basically, you build up some inflammation in your brain, you don't flush it out with the proper amounts of blood flow, and then you get a rebound effect of the blood flow and a spreading wave of depression through your brain, which you feel is that horrible debilitating pain, possibly visual symptoms, one side of your base or body going numb, nausea, vomiting, etc. Well, what we're finding is that possibly that inflammation is not getting flushed out of there because of the localized inflammation because of autoimmune conditions. And we've had patient after patient come in here with migraines who've had some pretty dramatic results. You can go on powerhealthtalk.com. And Hashimoto's has been a common theme amongst many of them. So migraines, what was the last one? Pernicious anemia, yeah. So we also see, that's pretty well documented in the literature too.
That B12 deficiency where you go get that shot and it makes you feel good for a couple of days.
Or if you have unrelenting acid reflux problems, you're taking omeprazole, Prilosec, whatever you want to call it, other antacids, and you're not getting relief, we check patients for pernicious anemia, and a lot of them have pernicious anemia, who have Hashimoto's. Because basically, think of it this way, Hashimoto's, as Dr. Rutherford said, is the canary in the coal mine. What we're finding is that Hashimoto's represents the immune system attacking the thyroid, which is basically a representation that your immune system has broken down. You've lost tolerance for yourself from an immune standpoint. What that means is that in your immune system you have millions of checks and balances that make sure that your immune system does not attack you. And in the Hashimoto's patient, those checks and balances are breaking down. Once you have Hashimoto's, you're more likely to have other autoimmune conditions, and that's why Hashimoto's goes at a higher prevalence with lupus patients. It's seen more often in rheumatoid arthritis patients, Sjogren's patients, you see it with other autoimmune conditions. This is why. And so this is the burgeoning research on Hashimoto's and how it relates to so many different conditions. And really, when you think about it, think of the underlying causes that we went through from a functional medicine and a functional neurology standpoint, which include gastrointestinal reactions to foods, leaky gut, think of it that way, bacterial imbalances, viral infections in the thyroid, and then stress patterns, overactive fight-flight responses that are not being mediated.
Right, and if you've gone to an alternative practitioner and say, well, I'm doing that, I'm giving you adaptocrines. That's not, adaptocrines are for like normal, daily, everyday stress. It's not for these emotional traumas. It is the significant fly in the ointment, because who would think that you have to calm your brain down to dampen your thyroid response?
Exactly. So if you find this interesting, you can go to powerhealthconsult.com. There you can find information about how to become a patient if that's something you want to do. We like putting these videos out so that we get the information out. We get messages from across the globe of people thanking us because finally they're getting answers. So we're wanting to continue that, but we do get requests to be a patient. So if that's what you want to do, go to powerhealthconsult.com. The information is all there. And I think that pretty well summarizes it. Was there anything else we needed to?
No, that's, I mean, honestly, we could talk about this for 3 days.
Yeah, we could.
There's so much, and if anything, maybe it makes you think twice about pursuing your Hashimoto's further if you are not satisfied, given your now understanding. And I think with all the things that Dr. Gates just connected to Hashimoto's, it may just be the tip of the iceberg, because now the research focus is on it, and it seems like every month or two he comes up with something new from a new research paper that helps our clinical expertise.
Yeah, and the other thing is we'll have, I'm assuming it's going to be around 100 references for this broadcast. So we'll have that attached when you find this talk on powerhealthtalk.com. And so as Dr. Rutherford said, we literally could talk about this for 3 days because there are so many more salient details involved that are really, really important and interesting, but we're trying to be succinct relatively for this broadcast.
Hopefully you understand why maybe you've gone through some frustrations of trying to get an answer, or maybe why you've gone through individual treatment protocols for the different things that we've talked about, but why maybe you didn't get that response because now you understand that it's a multifactorial problem. And so we hope that that cuts through what we call the BS for you, and we hope that that gives you a better opportunity to explore the possibilities on your own, to be able to get better, or for you to share this with maybe your loved ones or your friends, so that they have the opportunity to also understand what's really going on with them and seek out some treatment that can be that can actually be effective for them.
So we get requests to evaluate people's cases from all over the globe. If you want us to look at your particular case, you can go to www.powerhealthconsult.com, and on that webpage you can access information on how to get evaluated by our clinic. We hope this was helpful, and we look forward to talking to you soon.